So after the benign tumors, the next topic which we will discuss in this section are the premalignant lesions. And these premalignant lesions can be the cystic lesions, or in the cystic form they can be leukoplakia, and then also we will talk about the histology and the clinical features of the premalignant lesions. Cystic lesions can be mucocele. Mucocele is common in the lower lip. It's a retention cyst of minor salivary glands. So mucocele is the retention cyst of the minor salivary gland. The lower lip is mostly affected by the mucocele. It's soft cystic bluish lesion or blue lesion. Treatment is the surgical excision of the mucocele. So mucocele is a cystic type of premalignant lesion, which is a soft bluish lesion, and it is a retention cyst of minor salivary gland. Other cystic lesion is the ranula. Ranula is the translucent lesion in floor of the mouth. So it is present in the floor of the mouth. It develops from sublingual salivary gland, from the floor of the mouth under the tongue, and sublingual means under the tongue, salivary glands, which are the minor salivary glands present under the tongue. So ranula is developed from those minor salivary glands, sublingual. Some are plunging type. Treatment is complete surgical excision. This is the portion under the tongue. When tongue is elevated, you can see that this ranula is formed in that portion. Another is the dermoid cyst, is common term used, so it's a cystic lesion, the dermoid. It's two types, sublingual and submental dermoid. Sublingual is under the tongue. This is the under the tongue dermoid, and then the other one is submental. Mental is for the chin, so it's under the chin. Sublingual is median or lateral above mylohyoid, and it's like a white mass. Sublingual. Then submental is below the mylohyoid, and there is submental swelling behind the chin. So these are the two types of dermoid cysts that can form in the oral cavity. We have the sublingual under the tongue, we have submental behind the chin, and the sublingual is white mass. It's above mylohyoid, and then the submental is below the mylohyoid. So these are the three types of cystic premalignant lesions. Then we have the other premalignant lesions in which there is leukoplakia, erythroplakia, and the melanosis and mucosal hyperpigmentation. Leukoplakia is the white patch. Leuko is white. Erythroplakia is the reddish patch, erythematous patch, and then we have melanosis. Melanosis is from the melanin cells, which are the pigment cells that produce the pigment in the skin. So it's due to the mucosal hyperpigmentation or increased pigmentation. Leukoplakia. Leukoplakia is white patch. Leuko is white, plakia is patch, leukoplakia. Males are affected 2 to 3 times more commonly with leukoplakia. You can see these are the white patches that are formed. It is common in the buccal mucosa and oral commissures. And some etiological factors that leads to leukoplakia: smoking, alcohol abuse, ill-fitting dentures or cheek bites, associated with submucous fibrosis, and there is hyperplastic candidiasis. Candidiasis is the fungal infection caused by the Candida albicans, and this candidiasis is very commonly associated with leukoplakia. White patches are formed, and this is due to candidal infection. Then Plummer-Vinson syndrome, this is the syndrome caused by the iron deficiency. There is iron deficiency anemia, and people who have iron deficiency, they can have this leukoplakia in Plummer-Vinson syndrome. Then histology and the clinical features are the 25% there is epithelial dysplasia, mild to severe dysplasia of the epithelium, 25% cases. Higher grade of dysplasia, then there is malignant transformation, and just keep in mind we are talking about the pre-malignant lesions. These are the lesions that have the tendency to become malignant, and they are the leukoplakia. Then we have erythroplakia also. Leukoplakia is more common in the males. Different factors that leads to leukoplakia, we already discussed those. So on the histology, if the cells are more dysplastic, depending on from the mild to the severe type, if they are more dysplastic, poorly differentiated, more cellular changes are present, they are more prone to develop malignancy. So these are the leukoplakia white patches present. Clinical features are smooth or wrinkled white patch. So it may be leukoplakia, may be smooth, or the wrinkly white patches are present. Malignancy, nodules or erythematous base is present, and there are erosions and fissures are present known as erythroleukoplakia. So sometimes both erythro and leuko combine together. There are reddish patches present, there are the reddish base is present, and they are the nodular type lesions, so they can go into malignancy, and malignant transformation can also occur in the leukoplakia. 1 to 17.5% chance of malignant transformation. So in leukoplakia, sometimes it's a really high chance of becoming malignant, about 17.5, that's a quite high ratio. Management is the many lesions disappear if causative agent is removed, if it's due to fungal infection, candida, if that is treated or gone, the leukoplakia is removed. This is the condition before and this is after and it's removed. In lesions, potential for malignant change is present, biopsy should be done. Suspicious small lesions should be excised surgically, and ablation with laser. So laser can be used to remove the patches, and biopsy is important because we already mentioned incidence is high of malignant transformation, which is about 17.5 max, and from the 1 to 17.5, and then the other it can be leukoerythroplakia. Both are present once there is malignant transformation, and there is more severe dysplasia, cellular dysplasia is present with more chance of malignant transformation. Cryotherapy, cold therapy is another treatment option. Premalignant lesions, other we have erythroplakia, which is red patch or plaque on mucosa. decreased keratinization in the erythroplakia, no sex predilection. In leukoplakia, we saw it's more common in males, but erythroplakia, they are the same in the males and the females. In lower mucosa, gingivo-buccal sulcus, mouth floor. So erythroplakia is more common in the gingivo-buccal sulcus and the mouth floor. Whereas the leukoplakia, we said it was more in the tongue and the other portions, but not on the floor of the mouth. Dysplasia, invasive carcinoma, so erythroplakia can become the malignant, and there is, depending on the dysplasia and invasion, it can be invasive carcinoma. Treatment is by excisional biopsy. And then we have also another premalignant lesions, melanosis and mucosal hyperpigmentation. These blackish patch you can see is due to the hyperpigmentation or increased production of the pigment by the melanin cells. Lesions of oral mucosa form malignant melanomas. So these are the pre-malignant lesions. We have erythroplakia, we have melanosis and mucosal hyperpigmentation. Biopsy is mandatory. So this was all about the pre-malignant lesions. Thank you for watching sqadia.com.